And thank you everyone for attending our Global Patient Safety Open Conference. And this is to celebrate and engage in the World Patient Safety Day, which is held by the World Health Organization. And this day is largely the objective is to enhance global understanding of patient safety, to increase public engagement in healthcare safety, and to promote global action to prevent and reduce avoidable harm in healthcare. So each year a different theme is chosen. And however, today we're approaching it in a more holistic global sense to try to kind of have conversations about health, patient safety in kind of several different senses. So my name's James Wells. I am a PhD candidate in veterinary oncology program, and also I am affiliated with CyberPatient. I am the Expert Series project lead. So the Expert Series is held by CyberPatient, which is our simulation platform. And the Expert Series is highlighting several different physicians who excelled throughout their careers to share what they have to say to medical students, nursing students, any other students and faculty involved in healthcare to really provide key insights and patient cases to the global community. So first of all, I'd like to introduce our panelists. So we have Dr. Alberto Ferreres from the University of Buenos Aires, Dr. Kieran Walsh from the British Medical Journal, Dr. Savvas Nicolaou from the University of British Columbia, and Dr. Susan Brien from the University of Ottawa. And I'd like to introduce each of them individually here. So first of all, Dr. Alberto Ferreres received his medical degree from the University of Buenos Aires in 1979 and his Doctor of Jurisprudence degree from the same institution in 1987. He trained in general surgery and surgical oncology at the University of Buenos Aires, and he then completed a Master of Public Health from Salvador University, and additionally a Master's in Health Administration. And this includes as well a fellowship in patient safety and medical errors from the Virginia Commonwealth University. So he's presently a full professor of surgery at the University of Buenos Aires and the chair department of general surgery at the Dr. Carlos A. Ocalandro Hospital. And he has a large focus in surgical ethics. Next, I'd like to introduce Dr. Kieran Walsh. So Dr. Walsh is a clinical director at the BMJ. He's a clinical lead of the medical education and clinical decision support resources at the BMJ. He has a vast amount of experience in online medical education, clinical decision support, face-to-face delivery of medical education, and both summative and formative assessment. His experience of using all these in programs to strengthen health systems, especially, this includes focusing on patient safety as well. And he's published over 200 papers in the biomedical literature. Next, I'd like to introduce Dr. Savvas Nicolaou. He's a director of emergency and trauma imaging at Vancouver General Hospital here in Vancouver, as well as a professor of radiology at the University of British Columbia. He's also the vice chair of undergraduate education and continuous professional development, and he completed his medical degree at the University of Toronto in residency in diagnostic radiology at University of British Columbia. He's been actively involved in teaching medical students, residents, and fellows, and has served as a mentor for many of them at the Faculty of Medicine. He's been involved as the director of undergraduate radiology education, where he's helped to integrate radiology into the medical curriculum. And I'd also like to introduce Dr. Susan Brien. She currently serves as the Director of Practice and System Innovation at the Royal College of Physicians and Surgeons of Canada, and plays an integral part of the Royal College of Canada's international initiative as the Vice President, Asia Pacific. Her portfolio includes overseeing new regional, national, and international projects, facilitating professional development activities, including team training, simulation, performance assessment, simulation accreditation, and curriculum integration. Dr. Brien previously held leadership roles including Chief of Neurosurgery at Le Centre de Santé et de Services Sociaux de Gatineau, where she currently practices as a neurosurgeon. She served as the inaugural Director of Operations for Quebec, Eastern Canada, as well as Nunavut, with the Canadian Patient Safety Institution, where she's responsible for national patient safety education. So that's enough for me. I'd like to jump into the questions here and start this discussion with our panelists. So thank you for our panelists for attending. We are incredibly grateful to have you here today. So first of all, our question here is going to be directed to Dr. Brien. So how can changes in safety and professional development translate to improvements in the quality of patient treatment?
Thank you very much, James, and good morning, good afternoon, everyone. It's a pleasure to be here. I mean, for many years, we've been advocating education, things like conferences and courses, to be a way to engage physicians in quality improvement and also engage other health professionals. And we know that education interventions on their own are actually not enough to improve and enhance safer care. The educational interventions really need to be a link to other strategies to implement improvement. And with regard to physicians have very typically been participants in national programs, either from their provinces or countries that so-called collect points or credits for the professional development efforts. And often these activities have been much more linked to their own personal whims or learning needs and less linked to system and patient safety and improvement. So really, to improve safer care, we need to think about those two systems coming together. Those systems of professional development for physicians and also healthcare professionals, and also those systems of quality improvement, so that physicians and their teams see quality improvement as a critical part of their own professional development.
Excellent. Would any of the speakers like to follow up on that? Dr. Kieran, possibly?
Yes, thank you. And I agree with nearly all of that. Just one extra point. Much of CPD in the past has been about knowledge, and sometimes just academic knowledge. But of course, we need to widen that out if we're to achieve quality improvement and patient safety to other outcomes, such as problem solving, procedural skills, communication skills, professional behaviors, team working skills, and see CPD as part of wider quality improvement, i.e., you have needs which are based on the needs of your patients and your organization, and then you plan to meet those needs and then follow a PDSA cycle of iterative improvement and to integrate that with CPD.
Yes, I think that national provincial programs, at least in Canada, that are responsible for professional development really need to consider a closer link to the promotion of safety and patient safety activities, and a really solid way of recognizing that. And in Canada, in both the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada are very supportive of that concept and are working with the medical regulatory authorities, which are responsible for licensing, to ensure that quality improvement activities are really merged together. Making this important work count, at least for physicians, is very important to enable them to be, that activity to be recognized as part of CPD activities.
Excellent. Thank you both. I'd like to move on to our next question of today. Back to Dr. Walsh, actually. And this is going to be focused on clinical decision support systems. So how can the current structure and utilization of clinical decision support systems be improved? And how is this predicted to change over time? And additionally, how will this shift with clinical decision support systems in the future? How will this be focused around patient safety?
Thank you very much. It's an excellent question. At BMJ, we've got our own clinical decision support tool, BMJ Best Practice. I should state that by way of competing interest. And currently, in terms of clinical decision support, we increasingly think that the future is now, and the needs of our users currently, particularly our younger users, are for clinical decision support that's evidence-based, that's continually updated, that's particularly come to the fore with COVID-19, where the guidelines from COVID-19 have been changing every few days, understandably, especially at the start of the pandemic. And so we've had to change the content in our clinical decision support every few days. Also, that it works at the point of care. So it needs to be practical or actionable decision support. And it also needs to be fast. If it's going to work at the point of care, you need to find an answer to your clinical question within seconds. And to enable that to happen in turn, that means it needs to work on mobile or whatever device that you're using, both online and offline via an app, and ultimately integrated into an electronic healthcare record so that you can access the decision support seamlessly without interruption of the clinical workflow. Clinical decision support is aimed at doctors, but it needs to be aimed at more than just doctors, also other healthcare professionals, and we need to think of patients as well if we're going to achieve shared decision making, which is ultimately the core purpose of clinical decision support. So we need to think about how we might provide patient information as well. Lastly, I would say clinical decision support needs to be comprehensive, but also needs to tackle real-world problems. Until now, most clinical decision support resources have focused on patients with single conditions, when we know so many of our patients have multiple conditions. And so we've recently launched a new add-on to BMJ Best Practice, BMJ Best Practice Comorbidities, to enable just that, to enable healthcare professionals to learn how best to manage patients with multiple conditions.
Incredible. Thank you, Dr. Walsh. Now, on a similar note, thinking about how technology and additional support in decision-making can be implemented, I have this next question directed at Dr. Nicolaou, and it has to do with artificial intelligence. So how do we uphold patient safety as we are increasingly implementing artificial intelligence into medical practice? And who is held accountable when medical errors inevitably happen and these occur under the decision-making of artificial intelligence technology?
Yeah, thanks, James. That's a great question. Yeah, I think definitely we're seeing, and I wouldn't call it artificial intelligence, rather augmented intelligence is the terminology that I would say more fits, what we're doing presently. There's a lot of benefit to augmented intelligence from a patient safety perspective at numerous levels of patient safety from an imaging perspective. I think how to uphold that, I think, has to come from the physicians being involved directly, because ultimately the responsibility has to lie with the physician. And primarily within diagnostic imaging, I think how that is upheld is through constant validation of whatever type of augmented or artificial intelligence protocols or programs are implemented. It always has to be validated, properly addressed, properly examined in good scientific validation studies before anything is implemented. And I think it can have significant benefits within diagnostic imaging, One that was previously mentioned, clinical decision support, alerting a physician to critical and urgent findings on a particular imaging examination. For example, there are numerous exams that are performed in the acute and critical setting with augmented intelligence. For example, you could be dealing with an acute stroke or a brain hemorrhage or a pulmonary embolism or aortic dissection. And that study the critical findings would be identified by the augmented intelligence and also alerting the physician that that particular imaging study should be interpreted initially over some other routine studies that might not have such critical findings that would impact patient care. I think understanding that, I think, is critically important in helping addressing some of the urgent findings. So it could be used from that particular aspect. The other aspect that augmented intelligence could be utilized is helping and increasing the diagnostic confidence in identifying findings and pointing out findings to a physician. And that happens at all levels of medicine, but from an imaging perspective, where it becomes extremely useful, for example, that is implemented nowadays in routine diagnostic imaging, is the identification with particular arrows or identifying the evidence of C-spine fractures, pulmonary embolism, brain hemorrhage, acute strokes, active bleeding within the abdomen or the chest. That is happening today. Also, it's been implemented in COVID, where at the chest X-ray level, where it's increasing the diagnostic confidence of an imaging specialist in being able to identify early changes of COVID-19. That is pointed out on imaging studies. That is in the background, of course. But I think ultimately the initial interpreting physician has to take the responsibility by looking at what augmented intelligence identified and agreeing with it, because the responsibility has to fall with the physician. No software developer, no artificial intelligence company would take the ultimate responsibility of addressing the issue that you only have to rely on that particular software or artificial intelligence program. But I think it can be very useful, though, in helping a physician. And other routine stuff that it can be very helpful is in mammography for breast imaging, can be extremely helpful as well from that perspective, and screening for lung nodules on chest radiographs and computed tomographic studies. Other areas where we've seen augmented intelligence extremely helpful in imaging is the reduction of imaging times, particularly in magnetic resonance imaging, from studies taking over 1 hour, which can be an issue. It's very difficult for patients to remain still for an hour. Some of these intelligent algorithm protocols have reduced that type of imaging time down to 15 to 20 minutes, which can be very helpful, is what I would say. Other types of uses, we utilize contrast media in the brain to help us diagnose infections or tumor or neoplasms, and augmented intelligence is able to generate those types of studies without the utilization of contrast media, based on past experiences and based on other types of studies that have utilized contrast studies. You could actually eliminate contrast. Augmented intelligence has shown us that it can actually generate studies of what a contrast medium would identify. That can be done now with augmented intelligence. So there are many benefits, is what I would say. Ultimately, though, it has to be the responsibility of the physician, and these types of augmented intelligence protocols have to be properly validated in good scientific validation studies, is what I would say. The other thing that I just want to bring out that always happens in the clinical setting is the patient data. It has to be properly vetted and going through proper, legal standardization regimens to maintain confidentiality at all levels.
Absolutely. I can see how augmented intelligence can really reduce invasiveness, can reduce waiting times improve efficiency overall. And also thinking back about clinical decision support resources, these shared resources are really going to help with reducing any kind of impact on patients. And that leads to my next question here. Oh, sorry, go ahead.
So I was just going to say, yeah, a lot of, a lot of the expertise that is generated at, level one, academic centers, I think a lot of these protocols that are generated could be very helpful in serving a lot of the underserviced areas around the world and bringing that type of expertise through augmented intelligence.
Absolutely. That leads me to kind of thinking about communication between teams, using this technology, not using this technology, working with other groups. And this question is directed here to Dr. Ferreres. And it's covering what strategies can be used to better coordinate and communicate between different clinical teams with the end goal of improving patient care. Oh, sorry, Dr. Ferreres, I think you're muted at the moment.
Yeah, sorry. Good morning or good afternoon to all the audience and to my colleagues in the panel. Thank you, James and CyberPatient, for this invitation. It's a pleasure to share with all the distinguished colleagues my expertise. And I would say that the first strategy is that the teams need to be aware that errors may and probably will happen in clinical practice. So we need to organize, set up defense mechanisms to avoid damage or harm to our patients. Having said this, another point that we need to rely in the trust between the physician and patient relationship. We need to build trust. I am particularly against the concept of the provider-customer relationship. I'm not a provider. I'm a physician. I'm an expert physician. I'm an expert surgeon, and I try to offer the best to my patients. And when you are chairing a department or are in a leadership position, you need to lead by example, and you need to show your faculty and trainees that the patient is at the center of your concerns. So this has to do that the care that you need to offer is a patient center. And here I would like to recall a very nice editorial published in the New England Journal of Medicine, 1983, by Albert Johnson, Emeritus Professor of Ethics at the University of Washington at UCSF, where he considered the editorial is titled Watching the Doctor. And the first conflict that the physician confronts in his or her practice is that one between altruism and self-interest. So we need to be altruistic. And in that sense, we are going to be better physicians. And in that sense, we are going to improve team care and, of course, communication. Secondly, we need to consider the patient as a whole. I may be focused in surgical oncology. My colleagues will be the internist. Dr. Nicolaou is an expert in radiology, and Dr. Brien in neurosurgery. But we need to see the patient as a whole. And many times, what that request is a kind of orchestra director who will say, this is okay, and this orchestra director needs to be an advocate for the patients in order to prevent unnecessary procedures to be performed on the patient. Regarding the use of checklists, there is controversial information regarding this. So for me, it's a very useful tool, specifically in the OR. And we need to remember that the OR, the operating room, is the place where 40 to 60% of the medical errors happen. Another additional important tool to improve and enhance coordination and communication is the use of management plans. We call them SCAMs. We learned them from Beth Israel. And this acronym stands for Standardized Clinical Assessment Management Plans, which may be very useful in clinical practice. And I would also like to forward a word of caution regarding 2 points that were mentioned by the previous speakers. One is regarding evidence. It's important, but more important is the management and the dissemination of evidence, because the evidence may be in the library, but we know that most times clinical decision seem to be on the other side of the library, and not every clinician in every field looks forward for the evidence. But also we need to raise a word of caution regarding evidence, because you need to make, and I believe Dr. Walsh will agree with me, you need to be very critical regarding the use and the application of evidence. And I will mention an example. We are in South America, and we receive plenty of information regarding management of acute pancreatitis and pancreatic necrosis from European centers. But their cases are 50% related to gallstones and 50% related to alcohol intake. In our country, and I would say in Latin America, and that means Mexico South, 99% of acute pancreatitis are biliary etiology. So you need to balance, and you need to have a critical approach to the evidence. And the last, I would also like to raise a word of caution regarding the medical record, maybe the electronic or the handwritten, whatever you prefer. But if you go through the literature, you will see that the residents, who are usually in academic centers the most inexpert people to document the medical acts, take in average 2.5 hours to 3 hours just to document what's going on with the patient. And that's a lot of time. So and that's what we use to communicate between the internal medicine team, the cardiology team, the anesthesia team, the surgery team. We need to improve, and we need to find ways to improve this burden of work and to distribute this amount of work between the different physicians who are taking care of the patients or the department. And we need to improve, because from the medical legal point of view, when you assess an electronic medical record and a handwritten medical record, and this has been supported by the literature, the difference in quality and content, it's important. And it's much better, the handwritten medical record, than the electronic medical record. And I can tell you that whenever I'm in front of the computer, I just want to end as soon as possible. It doesn't take me so long time to handwritten a note in my patient's chart.
Dr. Walsh, did you have a note to add there?
Yes, thank you. Really interesting. Like, I think if you go back to the original definition of evidence-based medicine, it was about the research base, but it's also about practitioner and professional expertise. And it's also about the patient and the patient's preferences, needs within their environment. And where all those three meet, that's what evidence-based medicine should be. Unfortunately, you're right, it's too much about the research base. The point about the library and people thinking about evidence-based medicine is an activity that you might do in the library, that needs to change as well, and it's what we're trying to do at BMJ, so that you can access the library on a mobile phone or on an app, so that you have constant access to the information. Lastly, a point about the information itself. One of the core problems with evidence-based medicine is that it's been built amongst patients with single diseases, because patients with multiple diseases have often been excluded from the trials. Whereas we know that patients with single diseases are increasingly becoming fictional patients of the past. If you look at patients with COVID who become seriously ill and end up in hospital or intensive care, they all have chronic non-communicable comorbidities like heart disease, kidney disease, respiratory disease. And so our evidence-based medicine resources need to help healthcare professionals in those real-life situations that they're facing.
Dr. Walsh, you have made an excellent point, and thank you so much for your contribution. And if I'm allowed, I would like to take a brief comment about the decision-making process and a situation that we as surgeons are many times confronted in the OR, and how our department has brought some tools. When you have constraints of time and you need decision-making in the OR, you will be encountered, and many times the trainees or young faculty. So we implement an SOS team just to be on consultation online. You can call them by the cell phone. If it's requested or needed, they can return back to the hospital. But in that way, we prevent that the blend that you need in the department between the trainees, the young faculty, and the expert faculty, usually the old ones with white hair, it's all integrated in a team, and the young will operate in the OR any time of the day, particular night, but they will have the backup of experts, and many times when you are provided with the information, you can assist in making the right decisions for the patient. That's only my additional comment. Thank you.
Excellent. Great conversation, great discussion so far. I'd like to shift a little bit towards the educational component to patient safety. And I'd like to kick this off with another question to Dr. Brien. So, how can safety competencies be best implemented into an already crowded medical curriculum?
Thank you, James. This is a surprising challenge we still have. World Health Organization created competencies around patient safety, nearly a decade ago. And yet, to see specific behavior skills and expertise around patient safety, they've been quite slowly integrated in a more seamless way into curriculum of all healthcare providers. I think probably a decade ago, health professionals training would have maybe a patient safety day, or they might have a patient safety afternoon or a couple of expert lectures. And we certainly know that the integration of that type of content into a curriculum like that is not very useful or not very effective. And there really needs to be system-wide methods to integrate these important topics into curriculum. Now, there's no doubt that as things haven't evolved, there's been system-level levers that are pushing organizations and demanding organizations like accreditation standards to ensure that there's appropriate content inserted into both undergraduate, postgraduate, and professional development curriculum. And there's been the chance to also incentivize those types of topics that are related to quality improvement, and also are using more updated methods like simulation, in which there can be a more interesting and robust experience. But I'm not going to proceed in that direction. I just thought I'd mention a couple of really practical, easy things to think about if you're concerned and you want to ensure that you have some patient safety components within your educational intervention. So one of the easiest way to do that is when you're at the bedside or given rounds and you're talking about a particular case. There's always an important focus on the medical expert part of that case. And more recently, some focus on the social accountability or social determinants of health piece. And I think as teachers and leaders and faculty, if we can think of also putting just a patient safety lens on that routine case discussion. So you're not only discussing why the hemoglobin is low, but you might be also discussing the side effects or the risks or the safety issues that could come up around those particular cases. So the second thing to do, which has been very advanced in the last decade, is of course using the modality of simulation, either theater-based simulation or more recently in situ simulation, that really allows us to assess the competencies beyond just expertise, as others have mentioned, and looking at important skills and behaviors. And it's always more meaningful if you can link what might be happening with patient safety issues in your own context or your own region, and use that to create simulations that provide a meaningful experience for students. The other way, if you're using simulation as an educational intervention, is to think about when you define those objectives of those cases and the competencies that you want to assess, to include an objective that is focused on patient safety. So an easy one is maybe you're creating a simulation around a trauma case. Well, make one of your objectives something about hand hygiene and just insert it on top of the other objectives that you have in the case. And of course, another important thing with regard to the use of simulation and understanding about safety, we have traditionally used, of course, simulation scenarios, but more importantly, the debriefing portion, to practice those sort of rare events or to reenact something that didn't do so well. I think in a very interesting way, psychologists have been a lot more interested in what are we doing to keep things going in the right directions? What are we doing to keep the case on track? So less focus on rare events, less focus on reenacting something that went poorly, and more focus on what are we doing as individuals and teams to keep focused on improved outcome, that there's many ways to understand what are we doing right than only focusing all the time on what are we doing wrong. And my last suggestion would be, when we're thinking about putting quality and patient safety into the professional development type of curriculum or strategy, is really to think about the usefulness of campaigns. So what I mean about campaigns, in North America, it would be Choosing Wisely campaigns, the International Sepsis Alliance type of campaigns, ERAS, or things like the UK's famous PJ Paralysis campaign. So putting these behaviors and skills and important curricular pieces together in a campaign that involves the team and the patient is another really interesting, fun, and strategic way to incorporate patient safety competencies into your medical education activities.
Excellent. Thank you, Dr. Brien. And on a similar topic, got a question here for Dr. Walsh, and I know Dr. Brien covered a lot of how simulation can be incorporated into education and the benefits. But Dr. Walsh got a question here about e-learning as a whole. how can it contribute to quality medical education and specifically reduction of accidents in the clinic?
Thanks, James. Another great question. So e-learning has been around a while now, for well over 20 years. And so you might ask, well, how can we make best use of it? And I would say a number of A's. The A's are access, adaptivity, analytics, and assessment. So first of all, about access. E-learning offers massive advantages in terms of access, convenience, cost effectiveness as a result. So we need to make most use of that and ensure that our healthcare professionals can access the resources that enable patient safety. Also, adaptivity, so that the application can now change in response to the activity of the learner and the knowledge, perhaps, or skills of the learner. We have this technology now. We need to make better use of it. Also, analytics. The technology exists whereby we can find out for an individual or for an institution what the areas of strength are, what the areas of weaknesses are, what we need to concentrate on, what the gaps are. E-learning enables that. And lastly, assessment, be it assessment of knowledge and skills. To enable patient safety, e-learning can enable that. So I think that e-learning can be effective, but not just effective, but efficient as well. To go back to your last question, I think in your last question you mentioned curriculum and overloading the curriculum. So I got a quote from you for you here now, and I'll just take a second, give me a second to read this quote out. Time may be gained by the simple and common sense process of striking out of the curriculum that oppresses and bewilders the students, that distracts their attention from the real object of study, that loads their memory without training their intellect. Now you might ask, when did that quote from? Is that 10 years old, or maybe it's more than that? Maybe it's 1975. Wrong. That's 1875 in the BMJ, Robert Barnes. These problems have been around a long, long time. We can't keep squeezing things into the curriculum. We need to sometimes take certain things out of the curriculum, or as Dr. Brien said, we need to integrate the idea of patient safety and quality improvement into all aspects of the curriculum.
Incredible. That's a great quote. Thank you, Dr. Walsh. It's a crowded curriculum. Indeed. I'd like to move on. We've got two more questions from our panelists, and then we're going to open up to the audience for Q&A. This is the next question is directed here at Dr. Nicolaou. And it is focused on what are the logistical and operational considerations for patient safety. And specifically for Dr. Nicolaou, we want to ask, how does this factor in for radiation safety in terms of medical imaging?
Thanks, James. So I think what's important from the beginning is, we always adhere to one principle, the ALARA principle, meaning, trying to adhere to as low as reasonable, achievable doses in diagnostic imaging. And what we mean by that is that no matter how low the dose is or how minimal the radiation to the particular patient, does not mean we image a patient even though we can achieve an extremely low dose. It has to be clinically relevant and provide value in the medical field. And this is particularly important in the vulnerable patient populations, such as the pediatric populations, women's imaging, and the pregnant patient. With that said, an effective dose management program requires 4 elements. You need to collect and analyze the data from your radiation doses, monitoring software, use external benchmarks, and determine where doses could be optimized. Then you need to optimize your protocols themselves, and that requires input from everyone that's involved in imaging, whether it be from the radiologist, the technologist, but particularly critically important is input from the medical physicist to map out appropriately the protocol recommendations that move you from current parameters to recommended parameters. And that's critically important. The next step is a document review, create documentation of the protocol review and the tools that you utilize to achieve the modifications that you need. Having the proper documentation readily available to technologists, physicians, and physicists will help you meet those compliance requirements. And lastly, one important component is continuous quality and assessment. And you need to establish a continuous improvement quality management program and process at your institution, looking at both patient doses and the impact on patient image quality. This will help you stay on track with the your optimized goals. And it's critically important that there are proper dose optimization softwares now that are utilized routinely in imaging facilities, and that also alert a physician, a technologist, if you're exceeding the recommended dose ranges. And there are numerous bodies, one of them being the American College of Radiology, has developed excellent documentation of what type of study is required in a particular clinical scenario, also estimating the type of dose that should be utilized in that particular clinical setting. So it's important for the physicians, technologists, and the medical physicists to be properly educated at your institution. And why this is critically important is what I would say is that there was a recent medical legal implications at an institution in California, where there was, a very important type of study, which is CT perfusion that we utilize in stroke imaging in identifying the vulnerable, portion of the brain that could be salvaged with endovascular treatments, which is the gold standard now in acute stroke imaging. And so they started performing CT perfusion. They changed the protocols appropriately. However, there was no proper documentation, no proper dose monitoring. There was no proper input from the medical physicist. And unfortunately, they used their old protocol in CT perfusion. However, just to explain a little bit about CT perfusion, it's dynamic imaging that requires numerous sort of rotations around the brain to achieve this dynamic input that is critical in understanding the vulnerable area of the brain that needs to be salvaged. And they were employing these types of protocols for quite a time. And then over a couple of weeks, up to 3 weeks, there was a lot of patients that were returning back to their primary care physicians with radiation burns around the brain in a very distinct fashion where the dose was administered for the dynamic CT perfusion studies. So then an internal review happened, and they realized that there was no optimization of those doses and no maintenance in changing those particular protocols. And then California developed standards that you had to adhere to, or you would not be accredited. And that's the other thing that I want to mention. Particularly in Canada, there's a diagnostic accreditation program, and all facilities have to be DAP accredited before they can be properly legalized to perform imaging at any facility. The other measure that we've implemented at our institution and numerous institutions globally is any physician, whether it be a radiologist, an orthopedic surgeon, neurosurgeon, that uses radiation in any form in their medical practice has to take a radiation safety program that's done online, administered through the medical physics program and the radiology department for any physician to take a radiation safety program, and with questions asked, and that ensures appropriate quality and safety with continuous monitoring for those particular physicians that are utilizing radiation in their routine clinical practice. So there are numerous elements that need to happen, and but it starts with having input at all levels and continuous monitoring and optimization, and also relying on experts if so required.
Very important point and a great example. Thank you, Dr. Nicolaou. And for our final panelist question, bringing it back to Dr. Ferreres, it was previously mentioned that we need to acknowledge that these medical errors are going to happen. They're unavoidable. So once these medical errors, happen, how are they managed? And how can we improve upon the process that happens after, which is the legal process after a patient has been hurt?
Thank you, James, for this pertinent question. I will divide the answer in two. Regarding the first part, how are the medical errors managed once they happen? And I believe that the most important point is to know in which moment they are detected or discovered. If we follow Don Abedian's approach of structure, process, and outcomes, many times it's very difficult to discover the error meanwhile the process is ongoing. We usually analyze or assess the outcomes, and then we can go and perform different type of assessments to see if what has happened is a mistake or not. So beware, as I mentioned previously, that errors will happen, and you need to implement barriers in order to prevent them. But we are confronted to an error, which has undoubtedly happened. So you have to take into account 2 points. As we mentioned, the patient is at the center of our care. So the first point is said to the patient and his or her family, we are sorry. Apologies work. Of course, we need to know the truth of what's going behind, but in order to build trust in the medical and surgical profession from our patients, we need to apologize and say we are sorry. Third, which is as important as the apologies, is a policy of transparency, full transparency, which I implemented from my department. This, of course, is not easy because you are going to have the people from the patient safety and quality department backing you, but on the other side, you are going to have the risk management group will say they don't want to speak, they don't want to do this, and laws are really very stringent in our setting. You need to report the mistake, but for you to know the difficulties with the report system and implementation, quite different from the aviation industry, when the National Academy of Medicine in Argentina proposed the organization of a data bank where you could report errors on a very anonymous in order to serve other colleagues, this was encountered with a huge opposition from most professional associations, and this initiative was interrupted. So in this 5-step approach, I would say that would be the management of the error. Regarding the second part of your question, which is very pertinent, how can improve upon the legal process after a patient has been hurt? I need to bring some detail regarding the setting in most countries in Latin America, and this is regarding our legal system. We follow the tradition of the French law and, of course, in that sense, the Roman law. So the big contrast is that meanwhile, in the patient safety culture, we tend to think and believe, of course, that errors are of a systemic nature. When you go to the justice, the system starts to blur like my background a little bit, and the judge wants to know, pointing with his or her finger, who is the one guilty, who is the one responsible. So that brings the concept of the legal implications of errors. And adding to our legal organization, we do not only have an epidemic of malpractice litigation, but this malpractice litigation is both in the civil and in the criminal aspects. So in our legal organization, a physician may be found guilty and he or she may go to jail. This is very unusual, but that's a possibility that the law allows. So I remember I'm an expert witness, and in our system, there is an organization which is the Forensic Advisory Board, which provides expert witness testimony to all the judges, both in the civil and in the criminal aspects. I remember a judge who, after a patient had a fracture after a hospital fall, he was looking very eagerly to know who was the one guilty, the one responsible of this hospital fall. And I tried to explain him that this was an adverse event, that these things happen, but the physician who is in the OR cannot be held responsible for this hospital fall. So, and on the other hand, it's important that in the French tradition, professional liability is based upon three aspects, which is, one is unskillfulness, the second is negligence, and the third is imprudence. And of course, the errors are not to be blamed if they gather two conditions. One, the error is a gross error and is unexcusable. Those are the only two conditions under an error may be blamed, and the physician who was involved can be found guilty. I try to give you in a very short time an overview of our legal system and the legal implications. And I believe that this issue prevents an open discussions of errors in the medical field, because there is always this risk of professional liability, which is common ground in all Latin American countries.
Thank you so much, Dr. Ferreres. I'm sure there's similarities with other countries in Europe as well as North America as well in that regard. Excellent. Thank you so much to our panelists for covering the panelist questions. We're coming up to our 1 hour mark, but hopefully we can fit in one question here, maybe two from our audience. And the first question here I'd like to bring up is from Professor Godfrey G. Mendoza. And the question is, thank you for the information discussions. They'd like to know, how many evidences do we need before we can consider it as evidence-based practice in terms of research or evidences in practice? And this is an open question. Whoever would like to tackle it, please unmute and go ahead.
Yeah, I'm happy to have a go in the first instance. So our own process at BMJ is that we pay some regard to an individual case report or randomized controlled trial or whatever. There's a pyramid of evidence ultimately, and the top of the pyramid is systematic review and meta-analysis. So we look at all the available evidence from a thorough literature search led by information specialists, and summarize that and look at the whole body that exists. But once again, to reiterate, evidence-based medicine is more than just the literature base. It's more than just an academic exercise. It's also about professional expertise, deciding how the evidence might be implemented. And that's also about patient and preference, patients' preferences and needs. And it's also about the environment. Dr. Ferreres rightly said that the prevalence and epidemiology of different diseases is different in different continents. So one size doesn't fit all. You need to look at the evidence, but also look at your patient.
Does anyone else have anything to add on? Thank you so much, Dr. Walsh. Okay. Excellent. All right. So for our final question, this has to do with how, it's a very general question, how are nurses and even patients involved in the patient safety process? And how can they be further involved to a further extent? Again, open question, whoever would like to tackle it, please go ahead.
I'm happy to start from a BMJ point of view. BMJ has included patients in its work for 5 or 6 years now, from getting patients to peer review content to advise us on strategy. We also provide patient information leaflets alongside the information for doctors and other healthcare professionals. And we've learned a massive amount from the process of doing it, and we're really just at the beginning. We've only been doing it for a certain number of years, and there's still a good way to go. But we certainly feel we've made a start in the resources that I'm responsible for, and also the BMJ itself, the journal, the flagship journal itself, has made a massive amount of progress in that regard.
It makes sense to have patients part of that process. And would anyone else like to add on to that?
No. We are not able to speak about patient safety efforts just on the physician's side. It's the healthcare team, and in that sense, you need to involve not only nurses but all the other personnel in the OR, in the ward, in the emergency department, etc., etc. And of course, we need to involve patients, and you need to make them aware. And in that sense, we train them to, when they are receiving a medication, what's going on, what is this for, are you sure that you need to administer this to me, it's not the other patient, etc., etc. So I think that the patient's compromise regarding his or her own safety is really of paramount importance. However, there is another question that we as society need to improve, which is the issue of health literacy, which many times is a huge conundrum and compromises patient safety, because we see patients that are really very eager to follow every single indication, and they are not able to actively participate in the shared decision process. And you need to stimulate them just to ask answers or address their doubts, etc., etc. And I think this is a huge debt that we as society need to confront, which is the issue of patient literacy.